Okay, hello everybody and welcome to this Smoking in Pregnancy Challenge Group webinar on health visiting and relapse prevention. Thank you all for joining. I'm Jo Locker from Public Health England and I'm going to be chairing the session today. So we've got a really good programme ahead of us with some great speakers and time for questions and answers at the end after the first two presentations. Just some technical housekeeping things to go through first. If you do experience any technical problems during the webinar, you can use the chat function on the panel on the right hand side of your screen to let us know, and John and Vicky at ASH would do their best to assist and try and help you out. Just by way of introduction to the webinar, I'm going to just say a few words and go through a few slides before handing over to our speakers for the bulk of the time, and then picking up your questions towards the end. So the agenda you can see at the moment, Hilary, Wareing and Notley will be with us in a few moments. So if you do have questions as we go through, you can ask those by using the panel questions bar in the panel at the right hand side of your screen. So if you open that up, send us questions, as many as you like. We'd really like to be able to get through those at the end of the session after the speakers. So only we'll be able to see the questions as you type them, and we'll put a selection to the speakers during that Q&A session. If there are more questions than we can get through, then we'll try and answer those separately afterwards and circulate them in a separate document. So please do use that function. So just to introduce the Smoking in Pregnancy Challenge Group, for those of you that aren't aware, Challenge Group is a coalition of public health, maternity, baby and research organisations, all committed to reducing the rates of smoking in pregnancy. And of course, Public Health England, we've been working very closely with the Challenge Group over the last few years on a range of initiatives, producing resources and events and webinars like this. So the Challenge Group has produced three big reports making recommendations for government and local areas on local action to take the agenda forward and address smoking in pregnancy, and we now have a really wide range of local networks that we're regularly able to distribute information and resources to, and also hear back from you as well about what would be useful. So the work that we're doing now with health visitors is of course part of that. There's been a big focus on work with midwifery and that very during pregnancy time, but we know that it's really important to look at that before and after, as well as during pregnancy time. So the work with health visitors is really important, and looking at the different ways in which we can try and help to prevent relapse. So as part of that and as part of this work today, we are Smoking in Pregnancy Challenge Group is launching a new a new resource for health visitors, which has been designed to support conversations with parents. You can see it briefly, it's a bit small on the screen there now, but it is available on the Challenge Group website as of today. So this has been designed to support those conversations with parents, all members of the family. It's been developed with health visitors and trialled with both practitioners and parents, and you can also request physical copies of the resource if you like by emailing the admin at smokefree action email address you can see on the screen there. So hope that will be useful for you and a useful addition to the other resources that are on the Challenge Group website that hopefully many of you will be familiar with and we continue to produce. So just a bit more about where you can find information. Those are the links there. This is the number 4 in a series of webinars. So you can find the previous ones recorded on the on the Challenge Group website. This webinar will also be recorded, so colleagues can catch up if they're not able to make it today, or if you want to re-listen, of course, you can do at any time. And we'd also be very grateful if you would fill in the feedback survey that will be circulated after the webinar to help us take this work forward, think about what other topic areas we could cover, and give us feedback on how you found today's webinar. So that is all from me. What I want to do now is just introduce our first speaker, who is Hilary Wareing from who is Director of the Tobacco Control Collaborating Centre. And Hilary is going to be presenting findings from the insights work that she's been carrying out with health visitors and families over recent months to give us an update on what they found. So Hilary, I think over to you now, please.
Thank you. I'm just checking that you can hear me, Jo. Yes?
Yes, I can.
Great. Hi, everyone. I'm just going to do a very quick bit of background to how this work came about and why it's important, and then go through those insights that we found and what's happened because of that. So, single most modifiable risk factor in pregnancy. I don't think I'm going to be the only person to say that this afternoon. That's why this issue has got such a high national profile at the moment. And know that if women smoke in pregnancy, the impact that has both on themselves but also on the outcomes for their pregnancy and for their baby. And the fact that this is so modifiable if we take the right actions is why it's so important that we're able to do that. That also we're concerned about, it's not just about women smoking themselves, but we're also concerned about women having smoke-free homes during their pregnancy, and for them and their children to live in a smoke-free environment when they come home with a new baby. Lots of work going on around this, obviously, at the moment, but it's, as Jo said, it's been particularly focused on maternity and midwifery, but now it is very much time that we broaden that work out and looked at all the other groups who have involvement in supporting women to take action and stop smoking. And for health visiting particularly, I think this is the prevention pathway from PHE. It's really important to recognise the work that we can do around the time of pregnancy, and health visiting has a real opportunity around this because they see women particularly between pregnancies, and that preconception work, ensuring that women come to pregnancy smoke-free, is important. We also should say it's contextualised in the complexity of women's lives. We know that mothers and babies have better outcomes when they're not poor, they haven't got mental health problems, they're physically well, they're not smoking, etc. And for many of the women we'll be talking about this afternoon, it isn't just about smoking. They're living complex lives, and we have to address smoking within lots of other issues that need addressing. And also remembering that it's more likely to be the younger parents that are impacted, and that they are more likely to smoke and more likely to have difficulty quitting smoking. And so when we're talking about health visiting, we should also be including things like family nurse partnership in this discussion. Just to remind anybody who doesn't know, we've had a really good reduction in smoking in pregnancy. It's leveled off a bit at the moment, but that's not everywhere. Some places are making really good progress, and we know when we put the evidence in place that we can make the good progress. And there's lots and lots of work going on across the wider system to ensure we are able to apply that evidence base and support women. So as I said, don't just need the midwives doing everything. We need to think across the whole system who should be doing things, and where people may be able to have a brief conversation or a slightly more in-depth, challenging conversation with women to support them to take that action. So what do we do? Well, We've been involved in a project with PHE, with the tobacco team and the nursing team, helping to design interventions that will support health visiting and practice nursing to support women. And one of the first things we knew we needed to do was to ask women what the current situation is and what they would like. So we went out and undertook insights in 2 areas with women to find out what's happening now, what do you want? And it was a really encouraging exercise that women who smoked expect there to be a conversation. There's a real reticence sometimes amongst professionals to start that conversation when perhaps you're in the very early stages of building a professional relationship with the woman, but they expect it. They asked that professionals be direct and honest, that it needed to be related to them, so that they understood this wasn't just some theoretical risk. It can happen to me, it can happen to my baby. They thought it was important that it wasn't just a one-off conversation, because that mightn't be the right moment for them. It should be an ongoing conversation to support them to take action. And that we needed to ensure that we included not just them, but their partner, their family, other people around them, so that their support network understood the risk. One of the things they said was, you can tell me about not smoking, but I find it quite difficult to tell other people. And I need your professional help to do that and help others understand how they can support me and what they can do to help me and my baby be healthy. So the context was good. That had changed quite a lot compared to perhaps insights we'd done with pregnant women several years ago, where there maybe wasn't that expectation for a conversation. Now it was expected and accepted. It just needed to be upfront and honest, and not just once. And if you have the conversation, one of the key things was, if somebody asks me and I say I'm a smoker, they need to do something. It needed to be more than a question and a tick box. They needed to tell me what next, what support was available for me, what I should do. We also, at the same time, asked health visitors what they thought. 80% received no handover information from about women's smoking status. That made it difficult because they didn't know the current situation on perhaps their first meeting with a woman, either in the antenatal or the postnatal period. They considered smoking as one of many conversations that they expected to have, but were concerned how to do that in limited time and limited contacts. They reported that they do ask, advise and signpost generally, and that signposting was often to the GP or a local stop smoking service if a woman wanted to stop. They did report that those conversations could be quite difficult. However, the conversation about secondhand smoke seemed to be an easier and more acceptable conversation with women. So sometimes that was the direction the conversation went in, rather than helping the woman to stop. And they also thought that smoking isn't always seen as an important issue. And that was in the context of health visiting itself, but also within the organisations they were working with, and with the commissioning of their services. I should say that this information is a really quick summing up of what came back from interviews with health visitors, but also from surveys that came back from, well, we've got 1,300 surveys, online surveys back from health visitor and practice nurses, and over 2/3 of those were from practicing health visitors, which was really useful. And particularly from that survey, we noted that 95% of health visitors were not using CO monitors with pregnant women or new mothers, and 93% of health visitors actually said they wanted and perceived they needed more training to enable them to have that meaningful conversation with women and their families. We asked them kind of what were the barriers and enablers to them addressing this issue as well. And barriers and enablers always reflect each other a little bit as well. So it was a time issue. Feeling sometimes they were given such little time that it became a tick box issue. They just ticked the box but didn't have the time to do that broader intervention. Lack of confidence, so their training and knowledge was a barrier. Unclear pathways. So what do I do next? Who do I refer to? Have I got confidence in those people that I need to refer to? Concerns about the trust and relationship. And I think that was one that midwives had when they first started addressing this issue. And I think the insights from women have given us real confidence that it's not about what you say, as long as it's said with empathy and it's truthful. It's about how we do it, but there's an expectation that it is. And also a barrier was the normalisation of behaviours, because some health visitors told us around here, most of the women smoke, and that's difficult because it's not about her behaviour, it's about the behaviour within that community. Always easier if mum asks. If they have knowledge, those who previously been a midwife said that they quite often found it easier. They want good information, and I think that this maybe is an issue outside just smoking, but that handover information between midwifery and health visiting needs to have information about smoking and be timely. They saw having CO monitors as an enabler to that conversation, and they also saw that they needed the support from their organisations to do that, because if that wasn't there, it was more difficult to do. So from all that, what do we need to do? Build knowledge and confidence. That's what health visitors ask for. And to do that, we need to provide face-to-face training. There was an enthusiasm for having CO monitors, maybe not essential, but definitely seen as an asset. They needed to increase their confidence about other services that were available to refer those women to. Organisations need to work on better communication. We needed to get some specific materials. Health visitors thought the materials we have for midwifery were great, but did feel more like something the midwife would use with a woman and her family rather than a health visitor. So Joe's already talked about what's happened around that, and a priority being given to it within their organisations and within their commissioning. So we designed some training with the help of stakeholders from health visiting and associated professions and PHE, and we delivered some training to health visitors in pilot areas based on what they told us that they needed, and we did that actually with carbon monoxide monitors and without, to see what the difference was. And what did the health visitors tell us? Top tips, which is one of the things we did within training, was great. Role play or practicing something that's so emotive was really helpful in helping them think through how that was going to feel when they had the discussion back in their with their caseloads back at work. Learning more and feeling confident in their knowledge around smoking and secondhand smoke. The role play being real situation. They felt, the role play was on real situations they might have to manage. So those practice scenarios were exceptionally important. I have to say, everybody loved. There was nobody who didn't like the CO monitors. That was definitely seen, the same as it is for midwifery, as a huge aid to a conversation. So it may identify a smoker, but it also enables a conversation to open up and to go on to have those difficult conversations. They thought finding out what language worked best with women as well was really useful. And we got some really good pledges from the health came about what they were going to do to change their practice because of the training. Our big thing then was to the health visitors, and we were working with the Institute of Health Visiting with this project as well, is how do we get that training out? Because one of the things we'd realised, just like midwifery, is time for training is precious out there. It's very limited. So we decided to develop a training the trainer model. which has been done, and we have just piloted that training with a few areas, and those areas are now about to apply their training in the local areas, and we will be shortly getting feedback about that model of implementation to see if that is going to work. It's a 3-hour training session. We're doing the pilots in Hackney, Southern Health, Essex, Southend, and East Coast Family Nurse Partnership came as well to see how they might be able to utilise training. So from what we've learned about what's needed, where we're at, I just tried to do a quick bit of RAG rating. I think knowledge and confidence now challenging conversation is building, which is really good. And hopefully that can become green, because we've now got some face-to-face training which does that, and we just need to work out how we get that to health visiting staff. CO monitors, we've learned, is really important, and some areas are now providing their health visitors with that tool, but not all, and it's not essential, but it clearly is a really strong aid. Relationships with and confidence in other services, I think that goes along with the next one, improved communication and information flows between organisations. I think there's a lot of work going on around these, more to do, but we are getting there. We've just got the first specific materials for health visiting, and I know from what I've heard from those who've seen it, some very, very positive feedback about using the potential for using that new intervention. And I know that won't be the end, there's other things planned, but that's, I think, a really good start. And again, there is work being done around commissioning and providing and provider organisations, and looking at how we can ensure that this is a priority. And again, that's, I think, an ongoing piece of work. But I think overall, health visiting has kind of told us, yep, this is on our agenda, please help us have better conversations with women, and that we are all in the process of looking to how we support the profession to do that and help women not just quit during pregnancy, but come to pregnancy smoke-free. That is the key thing, I think, and the key challenge that we're all working towards. Thank you.
Excellent. Thank you very much, Hilary. That was a really great overview of what we've been doing, and the work that you and IHV have been carrying out across the country, developing and piloting the training. So some really good learning there. Before we hand over to our next speaker, can I just remind everybody about the opportunity to ask questions? So we've got a few coming in already, but plenty of time still to jot your questions down and send them in, and we'll try to cover as many as we can after Caitlin's presentation. So let me introduce Dr. Caitlin Notley from the University of East Anglia, who's going to provide us with a summary of the findings from a study that they've been working on into preventing a return to smoking postpartum. So Caitlin, over to you.
Thank you, Jo. Can you hear me okay?
Yes, can hear you. Thank you.
Okay, and thank you to Hilary as well. It's fantastic to hear all that insights work and really how well it aligns with lots of what I'm going to talk about in terms of our relapse prevention work. So my name is Caitlin Notley. I'm a senior lecturer at the University of East Anglia and have research interest in smoking cessation, relapse prevention, tobacco harm reduction, and particularly working with vulnerable groups, including pregnant and postpartum women. So I'm going to tell you today about our research to develop an intervention to support women who've quit smoking for or during pregnancy to stay smoke-free after the birth of their babies. In the UK, we propose that health visitors will be a really important part of this package of support, and I'm going to attempt in this presentation to give you a flavour of some of the feedback we collected from health visitors to inform our intervention development. Just to note, though, that the intervention I'm going to talk about today, we hope to formally test in the coming years in a large randomised trial, so it's not actually available for use in clinical services just yet. So I wanted to acknowledge the excellent research team that I've had the pleasure of working with, our funders, the Medical Research Council, and to confirm that we don't have any conflicts of interest. and also to thank the services that we've worked with as part of this research, particularly, of course, participants and healthcare professionals who took part in research interviews, but also the health visiting and midwifery services in Norfolk, our Stop Smoking service and local children's centres, who were all fantastically helpful in facilitating recruitment to our study. So, by way of background, we know that relapse to smoking postpartum is a significant public health problem and accounts for a large proportion of the burden of costs to our healthcare system attributable to smoking. The cost of returning to smoking after pregnancy is estimated at around £64 million every year, and that includes the costs of treating women who relapse to smoking and also the linked costs of treating infants exposed to secondhand smoke. However, there's a real opportunity for change here. Women who quit smoking during pregnancy have made a major lifestyle change, and in some respects they've done the really hard work of quitting smoking, and it's up to us to find ways to support them to maintain that positive behaviour change. Most young women of childbearing age are actually young enough to limit some of the long-term health complications of going back to smoking. So women who manage to stay quit from smoking can expect to live just as long as those who have never smoked. There's also a generational effect. So babies exposed to secondhand smoke have higher risks of cot death, suffering from breathing problems and infections during infancy, and children of smoking mothers are more than twice as likely to go on to become smokers themselves. So if we can support women to stay smoke-free, we're also preventing the uptake of smoking for the next generation. However, despite relapse being an important problem, according to a recent Cochrane review, there are currently no recommended interventions to support postpartum relapse prevention. In the UK, we don't have any NICE guidance and therefore currently no recommended routine provision of support. So our research is underdriven by a strong policy drive, as Hilary briefly discussed. We have the Cancer Strategy for England, which set a specific ambition to reduce adult smoking rates to 13% or less by 2020. In 2017, the Tobacco Control Plan for England set a target to reduce smoking prevalence in adults in England to 12% or less, and an ambitious target to reduce the prevalence of smoking in pregnancy to 6% or less. So preventing postpartum relapse is an important part of our drive to meet these targets that the Pregnancy Challenge Group was set up to address. In 2018, we had the Royal College of Physicians report on treating tobacco dependency in the NHS. This clearly states that as healthcare professionals, we should be looking for every opportunity to address smoking behaviour, and that multiple NHS contacts offer us many opportunities to intervene. So in the case of relapse prevention, there's lots of opportunities to potentially reiterate support for staying smoke-free. And then finally, and most recently, we have the NHS long-term plan, which emphasises a commitment to reducing rates of smoking in pregnancy and clearly states a commitment to prevention with a focus on supporting smoke-free pregnancy pathways, including support for partners of pregnant women who are attempting to quit smoking. At the population level, around about a quarter of what UK women report smoking in the 12 months before falling pregnant. So that's actually much higher than the general population smoking prevalence for women of childbearing age. However, very positively, many women do manage to quit smoking during pregnancy, and they often achieve this without support. So pregnancy is a really strong teachable moment, and many women are motivated to quit smoking for the health of their developing baby at this time. However, it's quite disconcerting that the majority of women who quit smoking during pregnancy relapse back to smoking quite quickly following the birth of their babies. So although estimates vary, we think between 50 and 90% of women who quit smoking for pregnancy will actually go back to smoking within 6 months. In 2015, we published a systematic review trying to explore all the potential reasons for postpartum relapse. So we synthesised all the qualitative research available at the time and found some very specific postpartum factors to be important. So, for example, although women are often motivated to quit smoking during pregnancy, this motivation drops or changes following childbirth, as the intention might have been to quit just for the pregnancy alone. There's huge physiological changes which happen in the immediate postpartum period. Many ex-smokers report the almost immediate return of cravings to smoke. And postpartum factors such as a lack of sleep, stress, worries about weight gain, or difficulty in adapting to the new identity of being a mother are also really important aspects of the postpartum period that we found to be important in impacting on smoking relapse, suggesting that there's a real need to develop an intervention specifically targeting this important time in women's lives. So in our PRES study, we undertook 3 distinct steps to develop a package of support. First, we undertook a literature review identifying potentially promising behaviour change techniques within existing published interventions to help us to map out a theory-based support approach that might be appropriate. Then we refined our ideas for a prototype intervention by undertaking qualitative work with women, both pregnant and postpartum women, ex-smokers and those who had gone back to smoking. And we also collected data from women's partners and healthcare professionals involved in the care of women postpartum. And finally, we modelled our prototype intervention using a person-based approach. So this involved working intensely with individual women to run the intervention in real time and gather detailed qualitative feedback to further refine the intervention. So this study has followed the MRC framework for developing interventions corresponding to the first 3 phases of developing theory, modelling and initial exploratory testing prior to a definitive RCT. So just to summarise our findings, in our systematic review, which is just published, we identified 6 potentially promising behaviour change techniques, which can be defined as the smallest components of an intervention to produce behaviour change. So some things that we found to be potentially important were things like problem solving, social support, and reducing negative emotions. So, for example, providing positive praise and support to staying smoke-free were particularly important. In the second phase of our study, we undertook qualitative focus groups and interviews with women partners and health professionals to try and gain valuable insights from the population that we're trying to target. So in our interviews and focus groups, we used visual prompts to talk through ideas about how an intervention might start, who might introduce the intervention, what form the support should take, so whether we should be thinking about written materials or electronic support. We also discussed how long support needed to continue for, and particularly we sought feedback on some novel types of potential support, so including text message support for women to stay smoke-free, the use of incentives or self-incentives, advice and support to use e-cigarettes or nicotine replacement therapy for lapse prevention, and then also thinking ahead to longer-term postpartum support. So some early feedback from women was that they felt that the intervention needed to be initially introduced by someone who they saw as a credible source of information. For most women, this was either the midwife or the health visitor. Written information in the form of a booklet was thought to be helpful for some people, but others really complained that they were overloaded with too much information during pregnancy, and they preferred electronic support, perhaps available via a website. Most of our sample used apps during pregnancy, though, and there was a real enthusiasm for delivering information using apps. Women suggested to us that an intervention needed to be initiated during pregnancy, so offering positive praise and support for having stopped smoking, but also preparing women for the immediate postpartum period where they would be vulnerable to relapse. Interestingly, often when we spoke to women, they felt secure in their status of being smoke-free during pregnancy. They didn't particularly see themselves at risk of relapse. But women we spoke to who were on subsequent pregnancies discussed how they had actually relapsed postpartum or felt they were at least vulnerable to relapse, and so more clearly recognised a need for support. There was strong support for text message support postpartum that might continue for quite a long time. Although responses to the idea of incentives for staying smoke-free postpartum were quite mixed. Many women felt that incentives for being smoke-free would be quite motivational, but some were uncomfortable with the idea of incentives. And with regards to e-cigarettes, it was felt that there was a real lack of information about the use of e-cigarettes, particularly in the postpartum period. Women wanted advice on e-cigarettes and breastfeeding, or whether they should be concerned about babies' exposure to second-hand vape in the home. Some women told us that they would use an e-cigarette if they experienced cravings to smoke, but this tended to be the women who'd already tried an e-cigarette before becoming pregnant, and other women were quite unsure about whether that approach would work for them. Women told us that they would really want partners to be involved in a relapse prevention intervention. And indeed, we know from evidence that having a partner who smokes is the leading predictor of postpartum relapse. So clearly it's important to involve partners as well. And there was also strong support for a social support group for mums who wanted to be able to discuss with other mums in similar situations staying smoke-free. And this was felt to be really usefully offered as an online resource because women like the anonymity of support or discussion groups online. So the health visitors that we spoke to during our focus group discussions also gave us some really interesting and helpful views that helped us to shape and define the intervention, particularly thinking about the feasibility of implementing an intervention within existing service structures. So we heard that health visitors do often address smoking with women and families in the home. However, they suggested to us that there was a lack of resources for relapse prevention particularly, and that it was often a missed opportunity because they were often unsure whether a woman had given up smoking for pregnancy because she simply presented as a non-smoker. Health visitors told us that the antenatal visit at home was a key time that a relapse prevention intervention could be started, and that support could then be reiterated by health visitors at the new birth visit, but the health visitors needed to be able to identify women quite easily who had quit smoking for or during pregnancy, and that was difficult at the moment. There was enthusiasm from health visitors for the idea of digital or electronic support, and this could be easily provided at low cost with minimal impact to the service, which was felt to be important. But there was some concern about who might administer and pay for a text message support service. It was also suggested that the health visiting service as a whole was trying to move away from paper and information leaflets, and therefore electronic sources of support were really positively viewed. And finally, it was felt that there was a strong need for a joined-up approach, so that women needed to be supported by midwives, health visitors, but also that health visitors needed to be able to work closely with specialist stop smoking services where this was required, for example, by making referrals for partners or family members for help to stop smoking. So health visitors' views on e-cigarettes as part of a relapse prevention intervention were quite mixed. Views were often unsure or confused. There was ongoing suspicion about the safety of e-cigarettes, particularly for long-term use. And also, as reported by women, there was felt to be a lack of information about the use of e-cigarettes in the postpartum period. So health visitors told us they felt underqualified to advise on e-cigarettes and really needed more evidence-based resources to point women towards. Health visitors really strongly supported involving partners in a relapse prevention intervention, but suggested that this had to be very carefully managed as they didn't want to alienate partners. So although partners could be difficult to engage, it was acknowledged that the postpartum period was a really key opportunity for behaviour change for partners. So for dads particularly, the reality of having a baby arriving following a pregnancy really hit home at this time and was a real opportunity for change. The idea of incentives was quite suspiciously viewed, I think it's fair to say, by health visitors. Particularly there was a concern about who would fund incentives for relapse prevention in an already cash-strapped system. But the idea of self-incentives, so for example helping women to calculate the cost savings of staying smoke-free and rewarding themselves with any money they saved, was really well supported. So health visitors alerted us to the very delicate job of maintaining positive relationships with women and families postpartum. They felt a moral obligation to offer evidence-based, honest advice about the harms of returning to smoking, but they didn't want to alienate women. So a health visitor here says that for us, there's a delicate balance of trying to build a therapeutic relationship with a woman, not wanting to alienate her, and being very wary about how they approach women about smoking because they want them to also be able to open up about important issues such as domestic violence, drugs or alcohol. So there's a balance there between supporting women to stop from smoking and not wanting to alienate them. Health visitors also alerted us to links with postpartum depression, the need to find positive ways to help women deal with postpartum depression that didn't involve going back to smoking, and the importance of making every contact count. So they really saw themselves in the health visitor role as having potentially multiple contacts with families where positive support to stay smoke-free could potentially be reiterated. Health visitors supported very strong links between breastfeeding and staying smoke-free, which again is supported within the academic literature. So health visitors reported that supporting women to continue to breastfeed often meant that they stayed smoke-free as well for longer. And this suggested that advice and information supporting both breastfeeding and staying smoke-free together as positive behaviours would be really useful. And finally, health visitors identified as issues concerns around third-hand smoke. So anecdotally, we heard that many health visitors give advice to smokers about changing clothing or washing hands after smoking due to smoke particles getting onto the baby. But they felt there was a lack of evidence-based information on this issue particularly, and there was a desire to have more concrete information that could be disseminated to families. And then one possible limitation of involving health visitors in offering relapse prevention support raised by health visitors in our qualitative work was the difficulties with service funding and the sometimes inconsistent service delivery, so particularly across different areas. Some families didn't get home visits or didn't get the regularity of home visits that they should have, and particularly this was the case for second babies or families who were deemed to be at low risk. So following from our development work, this is just a quick snapshot of some of the resources we've developed. We've named the intervention Baby Breathe, which is a positive brand name that received positive feedback from women and healthcare professionals. Initially, we developed an information leaflet, which is designed to give extremely positive praise to women for having stayed smoke-free. It avoids the negative images often associated with stop smoking literature. But crucially, this leaflet is really designed to facilitate a conversation and face-to-face support with a health visitor with women during pregnancy in order to prepare for the postpartum period. But as I said, the leaflet is so far untested and therefore not freely available just yet. Likewise, here's a snapshot of our website. This is an information-based resource based on their latest health evidence, giving lots of facts and information for women about the benefits for them and their families of staying smoke-free. It includes some interactive and tailored elements, such as a postpartum health timeline, a savings calculator, and this could be used as a motivational tool and to self-incentivize staying smoke-free. We also intend the website to be available in app format, and here's a glimpse of our app logo that we hope might become more familiar to you in the future. So in the final phase of our person-based intervention development, we received lots of detailed feedback about all the intervention components. I don't have time, of course, to go through all of these now, but just some headlines. We got very positive feedback on the Baby Breathe name and brand and the initial information leaflet. Very, very positive support for a separate leaflet targeted at partners, which was felt to be very important as partners were often overlooked. Text message support postpartum will be an important part of our intervention, as will the online website resource, which was felt important to be available as both a website and an app in order to support different preferences of women wanting to access information. And then an innovative aspect of our intervention is that women will receive a relapse prevention kit at around the time of birth. This we're calling the Baby Breathe box. It's based on the previously used NHS quick kits, and it was very well received by women. It will include further information, resources, advice, and some free gifts such as vouchers for a local coffee shop and a piece of nicotine replacement gum or a voucher for an e-cigarette starter kit that women could use if they experienced urges to smoke. So this would be a harm reduction alternative to returning to smoking. In this kit, we also intend to give very clear advice about using e-cigarettes in the postpartum period, drawing on the feedback that we receive from both women and health professionals. So this is an overview of the intervention pathway. It shows the initiation of the Baby Breathe package of support starting during pregnancy, probably initiated by a health visitor at the antenatal at home visit, although this could also be with a midwife or a GP. During the end of pregnancy, women will be given access to the Baby Breathe website and app, where they can read lots of information, access support, and input personal information such as their due date in order to tailor the interactive resources. We intend that women's status as a recently quit smoker should be flagged on her notes so that support to stay smoke-free can be reiterated and specifically mentioned by all healthcare professionals at subsequent appointments. And then at the time of birth, women will receive the Baby Breathe box relapse prevention kit, probably in the post. This box will be discussed with the health visitor at the new birth visit, which usually happens around 10 to 14 days postpartum. And then support can again be reiterated and can include active referral for cessation support, for example, for partners or other family members. Women will receive text message support starting from birth, offering very positive praise and support for staying smoke-free. And again, these text messages can be tailored so women can increase or decrease the frequency of messages or even opt out if they prefer. And there are some interactive elements too. So particularly when we trialled the text message system, we found that the quizzes were very well received by women. And then support will continue up to 12 months postpartum with access to the website and app, and text messages continuing but reducing in frequency unless individuals request for the frequency to be increased. So in conclusion, we know that relapse to smoking following pregnancy is a very important and prevalent problem, but women of childbearing age are young enough to minimise many of the long-term health implications of continuing to smoke. So there's a real opportunity to intervene, but currently no relapse prevention interventions available. So through a process of theoretically driven intervention development, working with women and healthcare professionals, we now have developed a well-defined, co-created intervention that is suitable for testing in a larger controlled trial. We're at the stage now of having applied for funding for the trial, but await the funding outcome currently. So thank you for your time, and of course I'm more than happy to answer any questions.
Thank you, Caitlin. That's really, really interesting. Great summary, and yeah, I think lots of us will be looking forward to hearing more about your results as the trial progresses. So yes, thank you. We have got a number of questions coming in, so that's really good. I'd like to invite our some extra people to join the panel, to join the question and answer session. If I can introduce Vicky Gilroy, who's the Projects and Evaluation Lead for the Institute of Health Visiting, and Clarke, who's a specialist health visitor for the Homerton University Hospital and NHS Foundation Trust. So welcome to both Vicky and Annie. You're on, and also Hilary and Caitlin are obviously still with us. So any more questions, do email those, post them, and we'll try and get to them. But before we go into the questions, just introducing Vicky and Annie. Would you like to just say a few words to introduce yourselves and just to sort of sum up where your perspective on health visitors' role in smoking in pregnancy relapse prevention is? If maybe I could start with Vicky. Would you like to say a few words to start with?
Hi, yeah, that's fine, Jo. So hello, I'm Vicky Gilroy. I'm a health visitor by background, and I'm currently working with the Institute of Health Visiting. I've been working directly with Hilary Wareing on this project and been involved in the public patient involvement and the development of the training and the delivery of the training to 5 groups of health visitors nationally and the Train the Trainer programme that Hilary talked about earlier in this presentation. I feel it's so important for health visitors to embrace this role and see the opportunity to support women to stop smoking. And having done the work with Hilary, the health visitors we work with are passionate about it, and we are in a great position to influence, even though our work is busy, as Caitlin alluded to, and sometimes we can feel that there are lots of other things we want to talk to about the woman. We can bring it into a conversation. I think listening to what women say if they want us to talk to them about it. So from the Institute of Health perspective, it's really crucial that we think about how do we weave in providing advice and support to women who want to stop smoking or to enable them to stop smoking in our core visiting and everyday practice. So I'm really excited to be part of this project and learned loads myself as well. So there's always more to learn. Thank you.
Hello.
Thank you.
So,
sorry, yes, hand you over to Annie. Would you like to say a few words to introduce yourself and sum up where things are for you?
So my name is Annie Clarke. I'm one of the high impact health visitors currently working in Hackney for substance misuse under the Homerton. And at the moment, as we stand, I'm one of the leads for the role, and I work alongside the midwives and the health visitors. And at the moment, we're able to do some joint partnership working. I've been quite fortunate actually to attend the IPIP training. So thank you, Hilary, because I found that training quite informative. And we've been quite fortunate because we're able to use the monitors in our everyday practice. So we have that first-hand advantage of going into homes and working alongside families to offer the CO2 screening, which is really positive. And we've seen a change in the practice that we've been providing as well. We've been noticing a lot of mums are quite engaging in the service that we're providing. And there's definitely a huge role for the public health to also deliver the training, and we're very fortunate to work alongside public health as well to deliver the CO2 training. So it's really, really been positive, and the mums have been quite receptive, so it's been quite good.
Excellent. Thank you very much, Annie and Vicky. Okay, so over to our first questions. There was a point raised, I think probably in Hilary's presentation, I know through the insights work with health visitors around unclear referral pathways in some areas, and there's a question here about whether there's been a recorded shift in sort of either direction really with this over recent years. Are our referral pathways getting better, or are they getting worse? And is this anything to do with the changing landscape for specialist stop smoking services? I wonder, Annie, if you could give us an overview of your experience in terms of working with your local stop smoking service and what you've done with referral pathways to try and find a way through the recent changes.
So at the moment, our pathway has actually improved. It's much better now. So we've actually been able to sit down and work with Whittington Health, who provide the stop smoking service. And we've developed a pathway, which is something that's now been disseminated to all the health visitors. So they're aware that they can do referrals via a simple email or a simple phone call. And that's allowed us to actually make that transition a bit more easier to do the referrals.
Excellent, that's great. So some real kind of tangible things that you've put in place to make that referral quick and easy.
Yeah, and we've also been able to partake in some joint working as well. So able to do the very brief advice training as well, which is something that we're now going to share out with all the health visitors. So at the moment, myself and two of the CO champions that we have, because we have a champion in each team, we've been able to sit down and actually partake in the very brief advice training, which is something that we found very informative. And now that we can share that out, that should hopefully make that partnership working more tangible, more easier to do. Sorry.
Great. No, that's really good to hear, and great that you've been able to use the tools and the training just from the pilot already, and hopefully that's something that we'll be able to spread to other areas as well. Vicky, I've got a related question here that you might have a view on in relation to a specialist stop smoking lead role for health visitors, and if this is something that that could or should be considered a specialist lead role for health visitors on smoking.
Yeah, I think, as Annie is one, she's tested me to the benefits of having that. And I know nationally from our work nationally, there are a number of areas who have health visitors who are taking a lead role in coordinating the pathways, the relationships with the stop smoking services, and that has been seen to be very successful and been seen to be a great benefit to the health visitors on the ground level to have one person they can go to, and also for the stop smoking services to have a key point of contact is really useful. Different places call it different things, and it does absolutely depend on the local landscape. And it is important that whatever service provision we put in place fits into the wide ranging, which you alluded to before, the wide range of different service models that are developing nationally. So any role that can support ground level staff have access and better access to pathways will ultimately support the women. So I can only see that it can be a good thing to have key people identified, whether you call them specialists or leads is a question to be answered, and a big debate, isn't it? And I suppose it's making sure those people have the training and support to fulfil the role, because there's no point just labelling somebody with something without giving them the resource or time to fulfil it.
Absolutely.
I don't know if you would say something, Annie.
Just to add, we're also able to collate the data in order to support the work as well, which is really good. So we can work alongside data analysis as well. So we are really on top of identifying health visitors that may need that specific work, and to be able to deliver the stop smoking advice that we share as well. I think that's really good, just to recognise that as well, and able to identify, making sure there's any if there's any glitches, we can iron that out as well, and just make sure that it's something that's collated as well. Because as Vicky rightly mentioned, we're doing this work, but we need to collate this data as well. So it's really important that we can recognise this. And I think the training is very, very important and needs to keep rolling out as well.
I think, Joe, what I would want to add to that is what you wouldn't want to happen is that, which does happen sometimes when we design specialist roles, that the main workforce needs the skills and competencies and the confidence, as Hilary talked about, to have the conversations. You don't want a situation where we end up anything to do with smoking being referred to a person. And as Annie said, the role needs to be about embedding and supporting the core service to deliver the service to the women, because they're the people that are seeing them on a daily basis. So I think we need to be careful about how we design those roles, so that exactly as Annie's role is working, that it is part of the core delivery, and every health visitor has the skills and competencies to support women to stop smoking is really key.
Yeah, I think that's really, really important point. Having some sort of specialist coordinating function and someone to champion and lead this work, but also making sure it's well embedded across all of the practitioners working in that service and across the system. That's a really important point. Hilary, there's just leading on from that, there's a question about the train the trainer model and when and how people might have access to that. Did you want to say a few words about how people might be able to access that, or thoughts on where we are with that at the moment?
Sure, and it is thoughts at the moment, because it's only 2 weeks since we undertook our first training the trainer, and we're just evaluating that, and we're obviously waiting for feedback, which will take some months to come back from those sites. In were the tools we gave them fit for purpose? Did they work well when they went out to train their health visiting teams? But I would guess that if people give us expressions of interest in that, then as we know how that's going to go forward, we can keep engaged with you and let you know what's happening.
Yeah, thank you, Hilary. I think that's really important to say. We have developed the training, we have tested it, but until we can get results back from those who've piloted it with that it is actually doing the job that we hope it will, we need to keep hold of it and keep refining it to make sure that once it does become more widely available, it's doing the job it's intended to. Thank you.
Yeah, and also, Joe, we're kind of hoping we might have another resource to go alongside that might help with that soon as well, don't we?
Yes, absolutely. And I think Hilary's alluding to conversations that we are having with e-learning for health, Health Education England and e-learning for health to look at ways in which we can consolidate some of these resources to sit them alongside some of the smoking in pregnancy resources that already exist. So keep watching this space, and we are working on it. Caitlin, I have a question here around incentives and wondering what do you think the incentive actually looks like? What kind of shape or form, or do you think the incentive looks like, and how are people perhaps going to be accessing this? And a suggestion here that maybe is something that could be discussed with parents if they have, an infant that's got an illness that's potentially related to smoking, GP or hospital attendance, and they're identified as smokers. Is this where an incentive might be accessed? So sort of two questions: what does the incentive look like, and how might people access them or be identified as finding that a useful part of their smoke-free journey?
Yeah, so incentives is really interesting. We know from the academic literature and the Cochrane reviews that incentives for smoking cessation work, they're effective. But we were particularly interested in exploring the use of incentives for supporting people to stay stopped from smoking, so for relapse prevention, which is sort of a slightly different use of incentives. Really interestingly, as I said in my presentation, we did get quite mixed feedback on incentives. I think, women generally felt that they would work and be quite useful, but healthcare professionals were quite resistant to the idea of incentives. But really, across the board, we did find that the idea of self-incentives was generally acceptable and feasible and well-liked. So this might be something like encouraging women to save the money they would have spent on tobacco or cigarettes and use it as a treat for themselves for staying smoke-free. Some women preferred to use any money saved, for their baby, or to buy sort of expensive baby things that they might not otherwise be able to afford. But just small things to offer women kind of positive rewards for staying smoke-free, such as a voucher for use in a local coffee shop, can also be seen as incentives, which for some women are really important. Just having that recognition that they've done well by staying stopped from smoking can be really, really motivational. So at the moment, what we're suggesting within the pilot intervention is that we will use self-incentives via our website, so encouraging women to save their own money, but also we will include some small vouchers as a way of incentivising women to stay smoke-free as well.
Thank you. And there's a follow-up question here as well while you're on the line about the costs of the project and the baby breathe box in particular. Have you got any outline costs for those kind of elements yet?
Yeah, it's difficult to say exactly for the moment. Within the research trial, which obviously is sort of slightly different, we've estimated the cost would probably be around £10. So it sounds a lot, but when you look at the costs of savings for the healthcare system of people managing to stay stopped from smoking, that's actually only a tiny amount of money in comparison to the healthcare savings. So there is a cost that would have to be absorbed by commissioners, but that cost is quite small compared to the potential savings that we would be able to make.
Okay, thank you. And I guess there'll be more information on that as the project and evaluation progresses as well. There's no question here, or comment, I suppose, really. Often we hear that health visitors say that they don't have enough time to ask questions around smoking or make referrals. So that kind of pressure in the appointment and the time they do have with the women to get through quite a lot. So I wonder, Vicky, is that something you might be able to pick up on? And what can we do, or how can we work with our health visitors and commissioners when they say there isn't enough time to do work on smoking?
Yeah, and I think from doing the training, what all the health visitors, and I think Hilary will agree with me, all the health visitors, that comment did come up, and I know it came up in Caitlin's research as well, and the health visitors at the end felt that it actually fitted well into their core conversations at their core mandated visits, and actually just by shifting the conversation a tiny bit, it wouldn't actually take a lot longer. Obviously, if they're going to do interventions, that can take more time, and it's important then to work with commissioners to consider the benefits and the risk of not doing anything. And I think from all the research, it's really important that we must do something as health visitors. We are at that interface with another. So I think it is about how do we build it into the conversations we're already having. So we always talk about safe sleep. we talk about getting out, we talk about healthy, we talk about relationships and mental health. And it's how you can build the smoking conversation into what you're already saying, rather than it being a separate thing that you have to address on a list. And through the training, that was one of the key things that we were able to do, was actually through doing the role plays, as Hilary suggested, people really enjoyed that, was actually think about where in your normal conversations can you build smoking in without it having to be an add-on. So to me, it's so important to make the time. It's not a can do, it's a must do, but actually recognising that time is precious, and how do you build it into what you're already doing routinely. And the health visitors that we trained seemed to really embrace that, and they were already thinking about where in their current pathway, where in the conversation they are already having, could they build smoking into it, and building on that pathway from midwives. So knowing that the midwives are having the conversation, and the importance of then having the information for the midwives, so they're not starting a new conversation with the woman, they're building on a conversation that's already started antenatally. And if they're seeing the woman antenatally, having that information was key. So one of the things for commissioners is to ensure that the information from midwifery to health visiting is really clear. So the health visitors are not going in with no information. They're going in with knowing already where that woman is, what their smoking status is, and what intervention or action the midwife's already taken. So they're building on advice rather than starting from the beginning, which it can be challenging if you've got limited time.
Yeah, thank you, Vicky. That's really helpful. And actually, you've started to answer the next question that I was going to put to Annie in particular. Just picking up on that point that both presentations mentioned that often health visitors report they don't have data on women's previous smoking or current smoking status, and what can be done to improve data collection and sharing that across the maternity pathway. And Annie, I think so you did pick up on that a little bit in one of the answers to an earlier question, but would you be able to just say a little bit more about what you've been able to do with getting better data collection and data sharing in Hackney?
Yeah, so just adding on from what Vicky was just sharing. So in Homerton, we actually found that we've been quite good at accessing data from the computer system, which is what the midwives use. So we're able to collate information from their booking summary. So when mothers book in for their pregnancy, there's clear, specific information that's shared, and we're able to use that information to identify those mums that smoke. So then we can carry this through into our new birth visit. So again, when baby's been born, there's a discharge summary, which again also highlights the information of whether they've been ex-smokers, whether they're currently smoking. Again, it shares other issues such as mental health. So when we do that new birth visit, we're able to address that. It gives us the heads up, and as Vicky said as well, it allows us to have that continuity of information that flows between the health professionals as well, so that we're able to address that with clients. On top of that as well, we have what we call monthly GP link meetings. So the midwives, the health visitors, and the GPs will meet up once a month. And that's the opportunity for us to share information about mums that may be smoking, again, mental health and safeguarding issues. And that allows us to be able to identify those mums and, again, have that meaningful conversation as well. It's not something that's addressed just in new birth, because we appreciate from our learning, sometimes it may not always be the best place or the best time due to other pressing concerns that mums may have, i.e. breastfeeding, i.e. not being able to sleep due to other concerns. But again, we have that conversation at every contact, and we can have that at a 6 to 8 week contact, which is the universal contact which all mothers receive. And again, it's making sure that every conversation counts and every contact counts. Alongside with that as well, we're able to have data collected through our templates as well, which is something that we complete. And we're quite good at working alongside our data analysis as well. So we're able to identify mums that have been offered the carbon monoxide screening, mums that have declined, and then those mums that have declined, we're able to readdress that and find out why they've declined and get patient feedback as well, because I think it's really important to always improve the service, to find out what we as health visitors can improve. So again, we're always working alongside our data analysis to get monthly reports.
Great, thank you. That's a real system-wide approach to following that information through and looking at the different opportunities. There's two more specific questions that I want to get to. here. I'm going to take the first one on relating to practice nurses. Hilary, might be useful just if you could summarise where we got to with this work in terms of practice nurses. There's been a question around the role of health visitor and the contact time being reduced, and looking at other opportunities beyond the 6 to 8 weeks visit that Annie was just talking about, and asking whether any work's been completed with practice nurses around what their role could be with women and families, for instance, at the time of immunisation. So do you want to just let people know where that got to?
Sure. We included practice nurses within the online questionnaire, and we also did some insights with individual practice nurses, and we talked about the role of practice nurses with women during those insights. The role for women wasn't quite as clear because they maybe didn't have as much contact with them as with the midwife or the health visitor. The practice nurses, they did express they could see opportunities within their practice, but it was clear that perhaps they needed more help to think where those opportunities were. We did have a few practice nurses on the training, but we found it very difficult to engage practice nurses in the training, and since which we've been talking to commissioners and other organisations to think how better to engage practice nurses. With health visitors, they're in one organisation, and for practice nurses, they're spread even in one area across multiple organisations that have perhaps priorities and different ways of prioritising training. So at the moment, we are having some discussions with general practice to think how we can adapt to meet the needs of practice nurses, but they definitely identified things like opportunities in immunisations, at asthma checks when children come in with upper respiratory tract infections. So I think there's a huge opportunity, and therefore we can't ignore this. We just need to look at how to adapt our approach to fit that professional group better.
Thank you, and that is definitely an ongoing piece of work. We're nearly out of time, but I've just got one more question. I think possibly, Hilary, you and I might be able to pick this one up, but it's about information on e-cigarettes and people feeling there's a lack of information on e-cigarettes, and still obviously a large cohort of smokers thinking that that they're still more harmful, equally or more harmful than cigarettes. So a big potential to support smokers making the change. What are we doing about providing information for health visitors and others on e-cigarettes and having conversations with women about that? Do you want to touch on the resources that we're just updating, or the challenge group are just updating?
Yeah, we've got resources that we sent out on behalf of the challenge group to midwifery at the moment, both for professionals and for women, about e-cigarettes, and they proved to be really more than acceptable, extremely useful, and PHE and the challenge group are updating those at the moment because this is a fast-moving area where more and more evidence is emerging and we can give stronger and better advice. What we found in talking to the health visitor on the training is, particularly for women, they would value having access to, and that is one of the resources that's currently being updated. And I think we need to think about potentially could be access. Also, we focused on the training the trainer, because I think it's really important to enable professionals to have that debate in the training room, so they feel more confident in having that conversation with women.
Great, thank you, Hilary. So a couple of things there. The updated challenge group resources, so the Q&A larger briefing and being updated, the smaller version of that document as well, and being made available with some more specific questions and answers that relate to the work of the health visitor, and an infographic as well, and then also picking up in the train the trainer resources as well, so that that can be addressed in the training too. Right, we're almost out of time. There may be a couple of questions that we haven't got to. I'm really sorry about that, but thank you very much for submitting them. And colleagues at ASH will be able to package all of these up and try and get to some of those questions. The webinar has been recorded and will be posted on the Challenge Group website shortly. Please do fill in the survey about the feedback survey about the webinar and any other information you would like. And that just leaves me to thank both of our speakers, Hilary and Caitlin, for their really informative presentations, and then also to Annie and Vicky for joining the panel and answering the questions. Your contributions have all been much appreciated. And thank you everybody for joining this webinar. Bye for now.
Thank you.
Thanks, Jo.